Welcome to AETCM, the emergency medicine channel.
Yes.
An 80-year-old male came to the ER with complaints of fever, cough and breathlessness. On 10-second initial assessment, airway was patent, patient was speaking in full sentences. Breathing, respiratory rate of 28 per minute with saturation of 95% in room air. Circulation-wise, BP was 210 over 140 with a heart rate of 80 per minute. Capillary refill time was less than 2 seconds. Disability-wise, GCS was E4, V5, M6.
When BP is high, can you have a cardiac failure?
Yes, sir.
Which all conditions you can get high BP with cardiac failure?
So hypertensive heart failure can occur.
Okay.
It will cause to, sir, defect in filling of the heart. Diastolic failure will occur, sir. Because
high BP with cardiac failure. Okay, then.
Other conditions, CKD patients having high BP.
High BP. One more patient with high BP cardiac failure is not the correct answer. Tell me one condition that's a classical condition which will have high BP with cardiac failure. There are a lot of conditions, but tell some conditions. Who is saying? They are called as high output failures.
Yes, sir. Anemia. In case of
Anemia is
thyrotoxicosis.
thyrotoxicosis.
So then beriberi. Then
pregnancy.
Paget's disease.
Paget's
Pregnancy.
disease, pregnancy. These are the conditions where you have high cardiac output and cardiac failure. In aortic regurgitation with cardiac failure, what will happen?
Aortic cardiac low, it will be low output, sir. Aortic regurgitation.
AR is always high output, but once the patient develops cardiac failure, then the systolic BP will come down. Okay, so even then the systolic BP will be recordable, like it will be 120/80. Normally it will be 180/80, something like that. But when the patient go to cardiac failure, that systolic decapitation occurs. There are a lot of conditions where you can get the capillary refill time normal with a cardiac failure. Normally what we learn is capillary refill time normal means there is no cardiac failure. Okay.
And then exposure-wise, patient was afebrile and GRPS of 146 milligram per deciliter. Then, sir, adjuncts to primary survey, we had taken an ABG. Patient was having a pH of 7.35 with PCO2 of 27, with PO2 of 108 and bicarb of 18.1. Patient was having respiratory alkalosis.
What is pH?
7.35. Just lower.
It is lower, no?
Lower.
So it cannot be.
Respiratory metabolic acid. Respiratory alkalosis.
What is the bicarb?
18.1.
18. It is low.
Metabolic acidosis.
Acidosis.
Metabolic acidosis.
It is at least towards acidotic side. Okay. It cannot be respiratory alkalosis. Patient may have tachypnea to compensate that. Okay.
Sir, creat on the VBG was 3.3 and lactate was 1.2. Then, sir, CBC CRP point of care showed CRP of 9 with a total counts of 6,000, hemoglobin of 8 and platelets of 145. ECG was a normal sinus rhythm, heart rate was 80 with features of LVH was there, sir.
What are the criteria to diagnose LVH?
So we have the voltage criteria. So where the sum of R wave in V5 or V6 with S wave in V1 should be more than 35 mm.
Okay.
Then, sir, we had also asked for a TROPI point of care at this.
What is the difference between LVH alone and LVH with strain pattern in ECG? What is LVH by voltage criteria? What is LVH with strain? You can get a lot of LVH with voltage in your emergency room, thin chest wall, or somebody normally itself they can have very high voltage complexes. Okay. Some patients who is having real LVH also can have very high voltage. Okay. And what is LVH with the strain? ST depression, TO inversion. Okay, that's a type of ischemia, but actually it does not come under ischemic heart disease. When there is cardiac muscles are enlarged, that much blood supply is not there. So there is a demand-supply mismatch. Okay, that's why they develop ST depression with TO inversion, especially in the lateral leads, V5, V6. Okay.
So then coming to sample history, it's an 80-year-old male, known case of hypertension, CAD, status post PTCA, dyslipidemia and chronic kidney disease, not on dialysis. He came to the ER with complaints of fever since 2 days, associated with cough with expectoration.
When this creatinine started elevating in this patient, when the BP started elevating in this patient, these two things are very important. Whenever you are seeing an elderly individual with high BP with creatinine, it may not be always due to diabetic nephropathy or so many other conditions what we learn. What condition you develop hypertension with renal failure after 50 years other than diabetes? That is a common condition. At any age you can develop.
With renal failure.
Okay. An elderly individual coming with renal failure with high BP who never had high BP in the past or not a diabetic. Diabetic means any time he can develop. What is that condition? What is a common cause for secondary hypertension in elderly individual? Secondary hypertension. It is renal artery stenosis. Renal artery stenosis is one condition occurs in elderly individual because of atherosclerosis in the renal arteries that can occur after 50 years. Normally, normally the hypertension, that is essential hypertension, that all starts before the age of 55 years. If any patient starting the BP elevation after 50 years, especially with renal failure, we have to always think about renal artery stenosis. Okay.
So he came with complaints of fever with cough with expectoration since 2 days, following which he developed breathing difficulty since 1 day. He had also patient had complaints of epigastric heartburn, not chest pain, epigastric heartburn with on and off chest discomfort since 1 day. Patient had complaints of orthopnea as well as paroxysmal nocturnal dyspnea.
Which is more dangerous, orthopnea or PNT? Which is more severe? Orthopnea.
There were no complaints of chest pain, palpitations, vomiting or any decreased urine output. Then, sir, coming to examination. On general examination, patient had pallor and bilateral pitting edema was present. No clubbing cyanosis or lymphadenopathy. And coming to systemic examination.
Pallor in elderly individual, what do you want to rule out in ICU? Malignancy. So first thing is malignancy. 80-year-old male coming with anemia. First thing you have to rule out GI malignancy. Okay.
And then patient on respiratory system examination, bilateral air entry was equal, but patient was having diffuse wheeze and crepitations were present. On abdominal examination,
so what do you think that crepitation is due to?
Sir, at this time, maybe patient into pulmonary edema due to pulmonary edema. So, sir, abdomen examination, patient soft, patient non-tender and bowel sounds were present.
What specifically you look in abdominal examination in this patient? Soft, non-tender, bowel sounds, normal, all MBBS?
Yeah, so tender hepatomegaly could be there. And
this patient is having high BP. I already told there is a possibility. You have to look for bruit. You have to look for two important things. One is abdominal aortic aneurysm. There also you have to look for bruit. Second thing is renal artery stenosis. Both the areas you have to auscultate for any bruit. Okay. Otherwise your examination is incomplete. Bowel sounds, we are not here looking for bowel sounds here. Because he is not having any abdominal distension or any obstructive features are not there.
Okay, sir, other systems were within normal limit. So, sir, at this point, we had also asked for an X-ray and we had done an ultrasound point of care of the chest. So, it was showing bilateral diffuse B lines were present.
Okay.
So, patient, so at this time, sir, tropi point of care that we had asked for, that also came to be high. It was 647 nanogram per deciliter.
What is the problem of tropi in this patient? Tropi, CKMB?
Already patient is known case of CKD.
So renal failure, it may not be very significant. Sometimes without any problem itself, it can elevate.
Okay. So we had also sent for cardiac enzymes to the lab. So at this time, provisionally...
What is BNP level in this patient?
So it came out to be 32,000.
So it is high.
Heart.
Okay.
So, sir, at this time we have a provisional diagnosis of a patient having acute pulmonary edema. It could be due to anemia because patient's hemoglobin is 8.
Okay. What are the reversible causes of cardiac failure? reversible. That means you can reverse that problem which is precipitating cardiac failure. Already patient is having cardiac failure. Some conditions can precipitate
Hypertension,
hypertension,
anemia, infections, and then thyrotoxicosis.
Then anything else? Fluid overload.
fluid
There are few conditions which can be reverted once the patient come to emergency room who is having existing cardiac failure, but these things are there, you have to revert it. Okay. What may be the reason for anemia in this patient? We have definitely we have to rule out malignancy, but what may be the reason for anemia in this patient?
Anemia of chronic disease, CKD patient.
CKD. Okay. CKD is a reason.
So, sir, it could be acute pulmonary edema owing to either it would be infection-induced heart failure could be there. It could be pulmonary edema cardiogenic versus nephrogenic. But no urine output reduction history was not there. Then
can patient have pulmonary edema due to renal failure who is having good urine output?
Can be due to heart failure, hypoperfusion.
What is it called as? It's called as uremic lung. Uremia itself can produce toxic pulmonary edema like ARDS like picture. Okay, that doesn't mean that patient is fluid overloaded. Patient is passing urine, but high urea itself can present with pulmonary edema. That is slightly different from your routine pulmonary edema. Here the reason is due to the uremia. It is sometimes called as uremic lung. Okay.
So we started the patient on initially we started on BiPAP because patient was very much tachypneic.
So tell me the steps to follow in emergency room when somebody is coming with breathlessness who is having high BP. You are suspecting pulmonary edema. BiPAP is after third or fourth.
So initially we started on nitroglycerin.
What is the first thing you do? First is propped up position. Sit, make the patient sit. Then start oxygen. BiPAP will take some time, at least 5 to 10 minutes it will take. Okay, so then start oxygen. Then
last 6.
Put an IV line. These things are very important. If you go for ACLS examination, if you don't put the IV line and if you try to start classics, nobody will start because you have not put an IV line. So these 3 things you have to do in all patients. Okay, so put at least 2 large bore IV lines has to be put. Then you can start the treatment. So what are the treatment you give?
So we started the patient on Lasix. Initially bolus dose was given, followed by infusion. We started at 1 milligram per hour. Okay. Then we also started
on Lasix bolus is better than infusion, or infusion is better than bolus?
Same, only the bolus will cause
hypotension. Bolus will cause some hypotension. Infusion will not cause hypotension. Okay.
And then sir, we also
how much bolus was given in this patient?
80 mg.
80 mg. Okay.
And after that, sir, infusion was started. Then, sir, patient was also started on NTG infusion. Since BP was very high, we started at 5. It is given a 5 microgram per minute. We calculated the dose and 0.3 ml per hour was started. Okay. Then, sir, we also started him on antibiotics.
BiPAP is already
BiPAP always given.
Propped up position, oxygen, then BiPAP, then NTG infusion,
Lasix infusion,
Lasix and
antibiotic we started, sir.
Antibiotic. Okay.
And
what antibiotic? Why you are starting antibiotic?
So suspecting LRT fever with cough with expectoration. Now patient having symptoms of pulmonary edema. So sir.
So what antibiotic you want to start?
We started ceftriaxone.
Okay. What is the role of ceftriaxone in lung infection? How much it will cover? What is the coverage of ceftriaxone? What is the coverage?
Gram-negative organisms.
It is predominantly gram-negative. So if you want to treat somebody is having a lung infection, it is always better to go for a better gram-positive coverage. Ceftriaxone is an add-on drug to gram-positive infection. You can give augmentin, you can give doxycycline, azithromycin. All will cover gram-positive. Or you can straight away go for levofloxacin, moxifloxacin, like that. Okay. Ceftriaxone is a second line drug or add-on drug which can even cover gram-negative infections, which may not be covered by augmentin. Okay, so ceftriaxone alone is not a good drug, but it has got some gram-positive coverage. Okay.
So, sir, cardio consult was given for the patient. Cardio, like echo-wise, patient was having overall good LV, but grade 1 diastolic dysfunction he was having.
Okay.
So then patient was admitted under cardiology.
So what may be the precipitating feature in this patient who is having normal ejection fraction, that is normal systolic function, mild diastolic dysfunction, but patient has gone to cardiac failure. What may be the reason for this?
Sir, infection, anemia, no. And sir, CKMB came out to be 12 in this patient.
But you are told the echo is normal. CKMB, even if it is high, that is due to renal failure.
Hypertension.
What might have triggered the failure here?
Infection.
Hypertension. But you have not proven that any infection is there. That may be the reason. But BP is an important thing here, which can precipitate the cardiac failure, that we have started treating the patient. Okay. What all drugs can be used for this patient? You have started NTG. NTG, how long you can continue?
So 24 hours.
After 24 hours, what will happen?
Sir, its sensitivity will decrease.
What is that word? Tachyphylaxis. It can develop tachyphylaxis, and after that it will become ineffective. So you have to add some other treatment. So what are the treatment options you have which can be started for this patient?
So we can start the patient with hydralazine.
Hydralazine is one drug which can produce peripheral vasodilatation. That can be started. Then
so nitroprusside can also be used.
Nitroprusside is not a good drug because he is already having renal failure. It may not be a very good choice in this patient. Okay.
Then Lasix, ACE inhibitors.
Lasix is already given. Can we give beta blocker? What is heart rate here?
He's 80.
80. What is the basic pre-existing condition in this patient? Any other? CAD
is a hypertension, dyslipidemia,
CKD and diabetic.
Diabetic.
Can we start beta blocker in this patient?
No, sir.
Beta blockers are not safe. What is a compelling indication for beta blocker in diabetic patient? Compelling means you have to give. Which is the condition? Which condition you give beta blocker as a first line drug in a patient who is having high BP, who is having diabetes also? CAD. If there is an ischemic heart disease, that is the only compelling indication, or there is a tachyarrhythmia, something like that. Here there is not tachyarrhythmia, but you suspect an ischemic heart disease. Okay. Tropoe is elevated, we cannot believe that because of the renal failure, but even then you can go for a beta blocker. Which will be ideal beta blocker if you want to give in this patient?
Cardioselective.
Which one?
Carvedilol.
Carvedilol is a good drug for cardiac failure. Only problem is that long-acting drug. We prefer short-acting drugs in renal failure. What will be the drug of choice? Metoprolol. So metoprolol will be ideal choice in emergency room. What is the dose you give?
5 mg.
5 mg. So you can give 5 mg and wait and watch. Okay. If patient is given beta blocker in a patient who is having renal failure, there, like suppose you don't monitor the patient, there is a syndrome called as BRASH syndrome. What is that?
Bradycardia, renal failure. A is for anemia.
Hyperkalemia. So patient can have renal failure, hyperkalemia, and beta blocker aggravates both, and patient develops complete heart block. Okay. So that is a remote possibility. If we have very high renal failure, very high dose of beta blocker is given, not dialyzed, then there is a possibility of bradycardia. Renal failure itself is a possibility for bradycardia, hyperkalemia. Okay. So anyway, beta blocker can be tried in acute, but not a very good drug for chronic follow-up in this patient, because this patient can develop anytime bradycardia and other complications. Then which other drug you can try?
ACE inhibitors.
ACE inhibitors are not a good choice at all. They should not be given because creatinine is very high. What is the other good choice which can be used in patients who is having renal failure? You see a lot of patients renal failure here, no? What is the drug they use for calcium channel blocker? Which is the calcium channel blocker they use? Cilnidipine. Nifedipine is a drug of choice. Why? What is the difference? It's a long-acting, so it's a short-acting drug. Cilnidipine is a long-acting drug. This is a short-acting drug. So almost all renal failure patients will be on nifedipine. That is plain drug. Nifedipine, not nifedipine retard. It's all plain drugs. Okay. So nifedipine will be a very good choice in this patient. Okay.
Sir, then patient was admitted under cardiology. He was treated. 1 pint PRBC transfusion was given.
Okay. How do you manage the anemia here?
So hemoglobin should be in any CAD patient. Hemoglobin should be more than
More
10.
than 10.
10.
Okay, 10 millimeter. Sorry,
10
10 gram percentage is the target in this one. How do you achieve that target? Blood transfusion is only short achievement. Erythropoietin. So you have to give erythropoietin every week. You have to give 4,000 international or 5,000 international units. Okay.
So 1.3 RBC was transfused. The hemoglobin came up to 9.5.
Okay.
And then, sir, he was treated with antibiotics and Lasix infusions. Nebulizations were given for these. And sir, he eventually improved.
Okay. Electrolytes all are normal.
Electrolyte was normal. Sir.
Okay. Which all the electrolytes can go abnormal in this patient?
Sodium.
Sodium what level?
Because
What
these are
can
Lasix.
What can happen in sodium in this type of patients?
Fluid retention.
Dilutional hyponatremia. Okay. Potassium?
Potassium can increase
Hyperkalemia can be there. Okay. These are the two important abnormalities you can see. Diabetes? Anything is given for diabetes?
No, sir.
He's not a diabetic.
5.3.
Huh?
HbA1c was 5.3.
5. He's not a diabetic. Okay. Only he's having hypertension with renal failure. Okay. So in this condition, you have to roll out one important condition, that is renal artery stenosis. You'll do a Doppler study of the renal artery, and probably you have to roll out the abdominal aortic aneurysm also. Okay. There also you can get high BP with cardiac failure. Abdominal aortic aneurysm. If you find that abdominal aortic aneurysm with high BP, what is the drug of choice there? Beta blocker. So there the drug of choice is beta blocker. Beta blocker is safe in almost all types of hypertensive emergencies, except in which condition? It is contraindicated in one condition. What is it? Asthma. Asthma is a relative contraindication. Those who are having a problem because of beta blocker, it can be contraindicated. So it's a relative contraindication. One condition, it is absolutely contraindicated. What is that condition? Heart failure. Okay, heart failure is also relative contraindication. Complete heart block also is relatively it's contraindicated. What is the condition which can aggravate the BP, can increase after giving beta blocker? It is called as pheochromocytoma. It is pheochromocytoma. So whenever you have a suspicion of pheochromocytoma, a young individual, tachyarrhythmias, coming with high BP, fluctuating BP, intermittent BP, that condition beta blocker alone will not be a choice at all. In that condition, you have to give either
alpha blocker.
So you have to start an alpha blocker first, then beta blocker, or an alpha plus beta blocker. What is that drug? Which can produce both alpha and beta blocking activity? Labetalol. So that's why labetalol has gained popularity in hypertensive management. Almost all conditions you can safely use labetalol, including in pheochromocytoma. It may not be very good option, but if you don't have anything, you can even try labetalol because it has got both alpha and beta blocking activities. But ideal situation, you have to give an alpha blocker first, then you have to give beta blocker. What alpha blockers are available? What are the alpha blockers? CTP? Clonidine. Clonidine is a centrally acting alpha agonist. Clonidine is not the choice. What is the drug? There is a drug available. Huh? These type of drugs are used in prostate enlargement also. Prazosin. Okay. Prazosin, doxazosin. Prazosin is available. So prazosin is the drug of choice. What is available in our country, but that is available as normally SR preparations. Okay. Anything else you want to add? Nothing. So tell me something about cardiac failure. What is it? Two types of important cardiac failure depending on the ejection fraction.
So ejection fraction preserved cardiac failure and ejection fraction reduced cardiac failure.
Reduced means?
Sir, cardiac output will be low. BP
low.
will be
so it is mostly systolic failure. Preserved means?
Preserved means, sir,
diastolic failure. So this is a diastolic failure. what is the strategy you should follow in emergency room in a patient who is having diastolic failure? Systolic failure, everyone will know that you have to be very careful of all propped up position, everything. But diastolic failure, most of our diabetic patients, hypothyroid patients, all have diastolic failure. What precautions you should take? What can trigger the heart failure here?
Hypertension can trigger.
Hypertension can trigger heart failure everywhere. But what is the triggering factor in diastolic failure? Everything, whatever systolic failure can produce failure in diastolic failure also. So fluids, when you are giving IV fluids, you have to be very careful, because even if you give a small amount of IV fluid, like extra amount of IV fluid in this type of patients, suddenly they'll go to cardiac failure, and you will not be able to find out the reason for that, because the patient is not having any systolic failure. So when you are giving IV fluid, that much amount of water cannot be accommodated by the failing ventricle. It cannot take up more water, so the water can accumulate in the lungs. Okay, so these patients very drastically they go to pulmonary edema, and you will not be able to find out the reason for that. So we have to be very careful. But whatever condition which produces systolic failure can produce diastolic failure. Even systolic failure itself can produce diastolic failure at one stage of the disease. Okay. Okay. Thank you.
Thank you.